Now, where you're located?
Sure, Del. We're located on 2620 Constitution, Suite 104, right across from the hot dog shop. So listeners can call 412-830-STEP, S-T-E-P, or they can visit our website, www.premierfa.org, and that's PREMIERFA.org. We have, you can make an appointment on the website. You can look around, evaluate different types of services that we provide, different types of pathologies that I treat. Take a look around at the website, a little bit about me and a little bit about our team. Or you certainly can give us a call in the office, and we'd be happy to talk to you that way as well.
Fantastic. Now, if a patient comes to see you, do you guys take insurances? Is it all private pay? Or tell us how that works now that you're on your own at your own clinic.
Sure. So we're doing things a little differently. Again, a big learning curve for us, but it's, again, something to benefit the patient experience and the patient treatment. So we do somewhat of a hybrid model. So initially, when a patient would come to see me, we do a direct care consultation. In this way, I can spend about an hour with the patient to do the full exam, the history, the imaging like we talked about, and provide a nice treatment plan for the patient and answer any questions they may have. This way the patient isn't rushed through their appointment, and I'm not having to worry about all the documentation to submit to the insurance companies, checking all the boxes and crossing the T's and dotting the I's. After the patient sees me and we develop a treatment plan, depending which route we go, either MIS surgical suites or conservative options, the patient would continue under a direct care model. With the direct care model also, though, we do offer different types of services that insurances unfortunately just don't cover. A lot of those services would be like shockwave therapy, laser therapy, and regenerative type of treatments, or almost preventative type treatments. So we do want to offer those, but to be able to offer the type of practice that we have, we do things a little differently. Now, if a patient requires a type of surgery that would go to the hospital where they would undergo anesthesia, they would be part of the reconstructive surgery option, and that's where we do take insurance. We certainly like to make sure our VA patients are taken care of, as well as our Medicare patients too. So it's just a little different for everybody. So once you call in, we can talk you through it and let you know what is covered and what's not.
So it sounds like you're under your current model, you're able to take most patients. You don't have to turn anybody away. Mm-hmm. In some practices out there, they're just stuck with one type of insurance and things like that. So you really have the opportunity to see any patient for whatever their needs are. So that's great. And then when you go through their treatment plan, they'll know up front, if there's going to be a cost, what that cost will be. So that's part of your talk with the patient. Is that right?
Yes, that's correct. So one thing we didn't want was hidden fees, where later on you would get a bill that would say, well, insurance covered this, but now you're responsible for that. So everything is up front. You know exactly what the cost would be depending on what you're doing and what you're seeing me for. And we do offer care credit or different options for payment to the patient as well. And if you do want to do one of those types of regenerative services, such as the stem wave or the laser therapy, we do have certain packages. And we do work with the patient as best we can as well, because we want everybody to get better. And it's funny, I would do all this for free if I could, I promise. My partner and CEO, he always reminds me, we're not the Red Cross. We do have a family to take care of. So, but it's something that by doing it this way, we're able, again, to provide that different patient experience that I think is so valuable that we just don't have access to anymore.
Now, those that are listening have not heard Eddie's voice for a while, and I'm thinking people
delightful?
People want to hear Eddie. They want to say, Eddie, I know you've been sitting quietly. It's the quietest I've ever heard you for this length of period of time. This has to be hard for you.
No, absolutely not.
So
this is flashback.
Have you thought of some questions that you want to ask Dr. Hobozal while we have her here on the show?
How do you do a complete ankle replacement with all of the bones and all of the different angles that every bone has to be exactly correct? Otherwise, basically you're recreating chainmail with calcium.
That is an excellent question, and that's a great analogy.
I was saving that one, Dale.
Well, I think what's really important about the ankle is, like you said earlier, Del, the ankle is connected to the foot, So sometimes that is an oversight. And if you're not paying attention to the foot and the way a patient is walking and the relation of the alignment of the foot to the ankle, and you just do a beautiful total ankle replacement, well, that ankle replacement will fail if the foot isn't corrected first. So it's something we have to evaluate, the entire package. It's not entirely just bone. Sometimes we have to repair the soft tissue around it, the ligaments that support the total joint itself. So I would say the foot and ankle is by far the most complex, and I may be biased, but I would say it's the most complex in the body. There's just so many different bones, different ligaments, and obviously we're putting all of our weight onto those joints. So it's very important to evaluate, how in relation it works together. But we do have some really nice technology now, which I'm very excited about, the weight-bearing CT that we'll offer. As far as I know, there's really not one in the area. I would have to send patients to the Cleveland Clinic prior if I did want a weight-bearing CT. So having that into the office and having that available to my patients, especially for total ankle replacements, is going to be invaluable. Now with current technology, we're able to kind of dial in through the CT scan and know exactly what angles that we need to cut the bone for the ankle replacement to fit into. So you kind of do all the preparation prior to surgery. So you plan, so you're only cutting once and not twice, basically.
What is the benefit of a weight-bearing CT? Is that showing you where the pressure points are going to be? Basically in real time rather than the assumption with a flat CT?
Exactly, yes. So the weight-bearing CT, whenever we're taking x-rays or doing things like that, we want the patient standing. I know Del probably feels the same way when he's doing therapy. We want to see, how all of that weight is distributed, like you said. So when a patient is going just, to the hospital or wherever to have a basic CT scan done, they're laying down. So all those joints are opened up. We're not actually seeing the pressure on the joints or the pressure of exactly where they're, how they're standing. If it's a high arch foot, a flat foot, if the ankle is malaligned in a certain way, we're not able to really evaluate that as well as we could with the weight-bearing CT.
Would that be a single procedure or smaller multiple procedures? And what's the best case scenario timeline and best case scenario returning to the before time with rehab?
Yes. Well, that is fairly surgeon dependent. Initially, when I started doing a lot of the ankle replacements, and now we're on our third generation ankle replacement. So if you would have asked me 10 years ago, I was very specific about the type of patient that would be able to qualify for a replacement. And that patient would need to be thin, probably about 70 years old, and a little lady, So because we would go through an ankle replacement, in less than 10 years. And then the only other option would be to salvage. The replacement would be a fusion. And ideally, I don't want to fuse an ankle unless I have to. And that would be for certain patients with neuropathy, or a history of infection or things like that. But if I'm able to do a total ankle replacement and keep the mobility of the joint, then I'm decreasing the stress on the surrounding joints, which would be the knee or the joint underneath the ankle, the subtalar joint. And then that way the patient can remain mobile. So, doing this type of replacement is just going to allow the patient, to rehabilitate sooner. So what I like to do now is if I do have to do any kind of correction to the foot, say I need the foot is turned outward and I need to make the foot straighter by correcting the joints underneath the ankle, I will do that at the same time and then do the ankle replacement as well. Depending on how fast the bone would fuse on that patient, sometimes I'll try and utilize some therapies to, increase fusion, optimize the patient with vitamin D, utilize bone graft if needed. I get that patient moving a range of motion, sitting in a chair at week 2. Then I'd send the patient over to Del, and I would ask him to start doing a little more forceful range of motion, some passive range of motion. Sometimes I would tell a patient to sit in a chair and just kind of push a little pressure over their knee onto the ankle. But ideally, I want that patient walking by 6 weeks with their total ankle joint.
Does the range change for the Achilles?
It does, yes. So typically with total ankle replacements, I will do either a lengthening of the Achilles or the gastroc just to allow a little more range of motion for the patient, or really rely on physical therapy to get that patient back to where where that range of motion needs to be. A lot of times we do try and regain range of motion with our total ankle replacements, but a lot of times it's also basically a treatment to decrease pain so the patient can walk pain-free.
Dale, when Dr. Hobozal sends you a patient, what's the first thing that you've got them doing?
Well, typically we're working in, like Dr. Hobozal said, is pain reduction.
Okay.
Making sure the patient's comfortable. We follow the protocols that the physician sends to us. So if Dr. Hobozal, she'll send a protocol that says, start them out weight bearing is tolerated, or full weight bearing, or partial weight bearing. So we pay attention to that, and then we're working on initial range of motion. Sometimes it's non-weight bearing range of motion that we start with, but we want to get them up on their feet as soon as the surgery is stable enough to do so, and get them walking as soon as we can. The last thing we want to do is have people start to develop other issues because they're sitting around and they can't put weight on their leg, and then they start developing issues with their hips and their backs and things like that. So the sooner that we're able to get them up and moving, they're going to have better outcomes.
What are the parts that you order? What are they made out of?
Yeah, so typically titanium.
Okay.
Titanium's nice. It's very low reactivity, host reactivity in the body. We're also able to get an MRI with titanium to see things if we need to. So say a patient needs to we need to evaluate a structure near the total ankle for something completely opposite. That's not going to interfere with an MRI imaging. Different surgical vendors provide these different total ankle replacements. So there's two that I particularly like to use that I have researched and have the best outcomes in my opinion. So I'm very much based on evidence-based medicine. I've been invited to do an FDA clinical trial with one of the total ankles that's been around the longest. It actually is out of Switzerland. So I had the opportunity a couple years ago to go work under that surgeon in Switzerland and see the crazy types of surgery he does, that the reconstructions along with the total ankle, and the time that he does it in is just amazing. So being able to watch him operate and be a part of that total ankle has been really, really impressive. I also work and teach with another company doing different conferences and teaching residents and attending surgeons alike how to utilize this total ankle and the technology behind it. So been doing these for a while. Again, it's one of my passions that I really like, so trying to always improve upon it and learn different techniques and how to teach other surgeons how to do this is something I think that's very important.
When you get in touch and get the ankle, and I'm thinking the mechanics of it, do they come in small, medium, and large? There's a lot of nuance with the ankle. Is it all custom built, not fake bones, but titanium bones?
Yeah. Do you have a total ankle replacement? You sure know a lot about this.
No.
I think, did you tip him off, Dell? Because he...
No, my mom in orthopedics, and I've broken almost everything. So some of this I go, I remember that word. How custom built can I get my ankle is what I'm asking you.
Yes, well, you can get very custom to you for sure. So based especially on CT technology, we are able to have a good evaluation of what size that ankle is going to be. So it's usually by number, like a 4, 5, 6, or that's equivalent to like a small, medium, large.
Like a dress size.
Exactly.
Okay.
So the smaller the ankle, the smaller the number, so we have a good idea going into it. Again, once you get in there and you can make your own tweaks and do a little more bone resection if you need to after you evaluate. I think that's really where the finesse comes in. So it's just not like a step-by-step thing. You actually have to, you can adjust to it. So maybe, the CT scan called for a 4, but after I, did my cuts and did my evaluation and evaluate the soft tissue, maybe I need to use a 5, So they bring all that for me so I can kind of manipulate it as I need to intraoperatively. And then we have different size polys, which basically is the, what goes in between the two metal components that allows you to move up and down. So we'll trial those, see how much motion we get. We don't want too much motion because then the poly could actually subside, go, anterior, posterior of the ankle. But we don't want a big poly where that ankle's not going to move at all either. So there's a fine balance there. So the more you've done, the more you have a good feel for it. But yes, it is pretty much very custom to that patient.
For those that are watching on Facebook Live, can you show us the cage you brought in and what that's used for and how that works?
Yes, it's
This
definitely
is like
show
the
and tell,
coolest. This is.
Yeah,
I
we
want
have
to
a
make
little show and tell. So
want to make
if
a
you're,
lamp
if you're just
out of that.
listening, this is on Facebook Live right
Yeah.
now. I
Good,
think it was a
okay.
little slow to get up and running, but the Facebook Live feed is now running, so we can do a little show and tell now. So, so tell us what you brought here, Dr. Hobozal, and what you use it
Yes.
for.
Well, I might be a little partial to pink here, but but they, like we talked about earlier, they do come in neutral, typically mainly neutral colors, black, basically. But this is an external fixator, so it can either be really cool to some people that see it, or really daunting and scary to others. But I've used it for so many years, and it's actually a type of fixation that comes from Russia, from a long time ago.
It
From
looks like an erector set.
It does look like an
a
erector.
way cool erector set. Yeah.
You're just lucky I didn't tell her to put it on you for use you as a guinea pig. For
I
this
wore
today,
clean
Eddie.
shoes knowing you were showing up, though, so I'd had it covered. It's very cool looking.
Yeah, so we utilize these external fixators anywhere from trauma, so a patient that may have had a bad fracture of the ankle or a compound fracture where the bone was exposed, and now we're concerned with infection. So we don't want to put internal hardware like plates and screws in the body. So we have to use this initially to get everything realigned prior to doing the internal fixation. Or I use it on patients that maybe need a limb lengthening. So we actually can lengthen limbs through this and do some bone lengthening over time. We can do compression, distraction. Really, there's no limit to it. It's once you understand it well, you can pretty much put the erector set together however you want to, and there can be moving parts. So, maybe a patient has a significant soft tissue deformity, and we're slowly trying to move it over. So we are allowing the nerves and the soft tissue to heal along with the deformity. So we're able to do that through slowly correcting that through these different struts. There are some struts that you can put on these external fixators that actually move. And now we can do that through computer technology. So the patient can dial it in and move it themselves at home. So this is one I utilized with the company, helped kind of design it, and this was for breast cancer awareness for October. So I thought that was fitting to bring. But we have it in children as well if they need some type of fixator, and they can do a Superman design or, make it fun. So it's something, that's not going to be a terrible experience, that we can try and bring some fun into it and so they can show it off at their own show and tell as well. So, but there's a lot of things we can do with it. I've been very lucky to be trained in this. Not everybody is, and I think it's important to have, I guess, in your arsenal of training to utilize in a patient if they come in and they may not be a candidate for internal fixation, and we have to use external fixation first, say in a patient that may have an infection or an unstable ankle with Charcot disease. And so we can get this on, get everything stable, do what we need to do to treat it, and then we can take this off and then provide, intramedullary nail or some type of fixation, a fusion for that patient so they can walk again.
Dale, you've done a tremendous job. You've passed the audition. Dr. Hobozal, thank you very much. Dale Reckless has been my guest, and the doctor has been his guest on Teleforum. You want to wrap it up? You did the show.
Absolutely.
You know how to wrap her up?
Yep. So we have here today Dr. Kimberly Hobozal. She is a foot and ankle surgeon and specialist, and we are so fortunate to have you here in Beaver County to serve the residents here in Beaver County. Just opened up her new practice, Premier Foot and Ankle, and tell us again how we can get a hold of you.
Yes, you can call us at 412-830-STEP or find us on our website, www.premierfa.org. We're also on social media under Premier Foot and Ankle, as well on Facebook and Instagram. And Adele, if I may, we are doing, we just started this and we're really excited about it. One of the reasons we wanted, and I wanted to be in private practice was to give back to the community. So yesterday we were actually at Beaver Run Senior Apartments doing a little education for that community, but we're also starting the Healing Heroes program. So we have our first patient coming in today. So if there's anybody that would like to be nominated that's listening today, that you've been a hero in some capacity, in either the police force, a veteran, or anything that's given back to the community, anybody that's given back to the community, we want to honor you as well and bring you in for a service of your choice to help you heal.
Very nice.
So,
that's
yes.
great. Great to give back to the community.
Dr. Hobozal, thank you. Dale Reckless, I'm taking Monday off. You need to be here by 7:30.
Tune into the Coach's Corner every Wednesday night from 7 to 8 p.m. The show is hosted by Mike Azadian and John Parado, and will feature